Good evening, everyone. Hi, Sneha.
Good evening, Milind. Good evening.
Rajendra Singh जोरात है. Yes, yes. Good evening.
Rajendra Sinha.
Namaste, Dr. Milind.
Namaste. How are you, Dr. Mitra?
Yeah.
Good, good, very good.
Minal, I think you
Yes,
can
yes.
rename yourself. iPhone दिसतंय ना?
हा मी करते चेंज मग.
Yes.
आता मिनल क्लिअर दिसते एकदम.
हा थँक्यू.
Hi, Minal. Bug. How are you?
सर आय एम गुड.
Hello,
Yes.
Snehanjali. Hi. Mute आहेस तू. Unmute कर.
Good evening, everyone.
Good
Yes.
evening. Good evening.
Good
Good
evening.
evening.
Maximum people have joined from all the societies
Oh, good.
Yes.
except Akluz.
Very good. Very good.
Arushi Kazwe.
Yes, she is from Ichalkaranji.
Ichalkaranji. I know.
Ichalkaranji.
I met her. I have been to Ichalkaranji. Kolhapur, Ichalkaranji,
Yes,
Gadi,
yes.
Purna.
Yes, Veena madam from Miraz, Arushi madam from Ichalkaranji, Shailaja madam from
Yes.
Karad, Surya Kumar
Correct.
from Satara.
शीतलनाथ
सातारा.
कोलेंनी हँड ओव्हर केलाय ना आता.
Yes,
ही
yes.
आरुषी सेक्रेटरी आहे.
Yes.
Yeah,
Hello,
Welcome.
Sheetalnath
Hello,
was
everyone.
previous
Good evening.
secretary. Yeah.
गुड इवनिंग.
All 5 societies के president secretary को हमारा नमस्ते. From Haryana.
Namaste, ma'am. Namaste again. Namaste.
Hi.
Arushi is from Ichalkaranji, right?
Yes, ma'am.
Hi, Arushi.
Hello, sir.
Yes, yes.
नमस्कार.
Good
Where is
evening. Yeah.
Revati?
मी डॉक्टर स्नेहा भुयार, आपली सर्वांची फॉक्सी उपाध्यक्ष पदाची उमेदवार. मिलिंद.
मी मित्रा
So nice.
नॉर्थ झोन का उपाध्यक्ष का.
उपाध्यक्ष.
I should also do this. Namaste.
Hi, namaste. Yes. See, all of you have sent your nominations, all societies. Anyone facing difficulties because many of the societies have not received the nomination form.
Many
All of
of
you have
them have
received?
not received. Huh?
You
They're
have not
telling me.
received, sir.
So
Who
In
have
fact,
not
Dr. Milind, मुझे लोगों ने बोला कि जैसे वाइस प्रेसिडेंट नॉर्थ का है तो 1 लिखा है तो वहाँ नाम टाइप नहीं हो पा रहा है. पीछे के
अच्छा.
डिटेल्स आ रहे हैं पर जहाँ है तो मैंने तो कहा टेक सपोर्ट लो क्योंकि हमें तो खुद को नहीं आता. हमारे पास तो
Or
many
they can write and scan and send. That is another option they can do.
Okay, I'll
that
do
is what
that.
I told the gut English people, no? Pratibha Chavan, she called me की ते प्रिंट आउट काढून भरा पेननी आणि मग त्याचं PDF करून शेअर करा, मेल करा.
Yes, yes.
That is
Otherwise, I had sent them an example. I have sent one form where the names are filled up. Anyways, now let us
No,
see.
Dr. Milind, what is very important is the mail to which they have to return. It is
Yes.
they should not send it back to same. It is election
Exactly. Foxy, yeah, correct.
It's a different
And
email ID. they have
yes,
to use.
yes.
I think
But many societies have not received the email. That is another problem, you know.
so many people were telling me that, you know, I have been to Varanasi also, no? They said, Milind, when you came after me. So they were saying
Yes,
that we have
yes,
not received
yes.
the mail. So I'm really worried now.
Correct.
30th is the last date, no?
Yes, yes.
Shall we start now?
Yes,
Yes.
Madan, we can start, yeah.
Yes, Mehul,
Yes.
please start.
Okay. So, welcome all the delegates and faculties for the live Core Connect live webinar, which is initiated by AMOC Sexual Medical Committee, Adolescent Gynecology Committee, and Emergency Obstetrics Committee, in association with Satara, Miraj, Karad, Akluz, and Ichalkaranji Obs and Gynae societies. So first of all, it's my honor to welcome one of our convener, Dr. Madan Kamble sir. Sir is a chairperson of AMOC Sexual Medicine Committee and National Coordinator of Foxy Sexual Health and STI Committee. And sir was past secretary and president of Akluz Obs and Gynae Society and got
It's okay. It's okay, ma'am.
Yeah, thank you,
Okay.
sir. Hand over to you this session.
Good evening, everyone. It's my pleasure to having me today here for this wonderful session. It is a special webinar arranged by AMOG Sexual Medicine Committee and Adolescent Gynec Committee and Emergency Obstetric Committee of AMOGs. And I'm very happy to be associated with 5 societies of AMOGs, that is Satara, Miraz, Karad, Akluz, and Isalkaranji. And I'm very thankful to all the office bearers of these our 5 societies who have consented to be associated for this today's webinar. I welcome all the faculties for this session, all the chairpersons, our chief guest Kiran Kurkoti sir, guest of honor Dr. Milind Shah sir, Dr. Pardeshi sir, my co-conveners, respected Dr. Sneha madam, Meenal madam, both are the chairpersons of AMOGs.
Okay.
And today's chairpersons, Dr. Mitra ma'am, Shailaja Kulkarni madam, Snehanjali madam, from Akluz, Dr. Amit Chopde, Dr. Kavita Kamble, and Dr. Arushi madam, and the chairpersons, Dr. Jyoti Rokde, Supriya Arwari, and Surya Kumar Khandare. These are the chairpersons for today's 3 sessions. I also welcome all the presidents and secretaries, Dr. Veena madam from Miraz, Dr. Shilpa madam from Miraz, and from Karad Society, Dr. Preeti Deshpande and Dr. Vidya Thorat. From Satara Society, Dr. Sanjay Zadhav is the president, and Dr. Surya Kumar Khandare as secretary. And from Akluz, Dr. Revati Rane as president, and Dr. Kavita as secretary. And from Ichalkaranji, Dr. Mandan Deshpande sir as president, and Dr. Arushi madam as secretary. I welcome all once again, and I hand over to Sneha madam for e-lamp lighting and to welcome the guests. Over to you, ma'am.
So thank you, Madan. A very good evening to
Yes.
all of you.
Let me introduce first, ma'am. Let me introduce.
That's a matter.
Yes.
Okay.
Madam is currently Madam is the past chairperson of Breast Committee FOXI, governing council member of ICOG, and chairperson of Medical Disorders Committee in the past, and currently Emergency Obstetric Committee, what she is heading in the AMOGs. She was past president of Yavatmal OBGY, and IMA also executive member of AMOGs. She is a great FOXian and great academician, very active lady from AMOGs and FOXI. And she has so many awards and accolades in her name. Also, she has conducted so many conferences at Nagpur, Pune, Zonal AMOGs, Lactacon, Breastcon, etc. And over to you, ma'am.
Thank you. Thank you, Madan.
Thank you, ma'am.
A very good evening to all of you. My respect and regards to all the seniors present here. And of course, a very warm welcome to our chief guest, Dr. Kiran Kurkoti, the AMOGs president. I think he had to join here. And guest of honor, Dr. Milind Shah and Dr. Rajendra Singh Pardesi. I also welcome all the faculties, mainly the speakers, and of course the co-conveners, Dr. Madan Kamble and Dr. Meenal Chidgukar. I welcome all the chairpersons here, Dr. Mitra Saxena, Dr. Sujata Kulkarni, Dr. Snehanjali, Dr. Amol Chimote, Kavita Kamble, and Dr. Arushi Kazwe, and of course, Dr. Jyoti, Dr. Supriya, and Dr. Surya Kumar Khandare. I welcome all of you. I also welcome all the president and secretaries of all the 5 societies. Madan has already taken all of their names. So to just curtail the time, I would just welcome all of you here. And of course, I would like to welcome the chief guest, but I think he has not come here. So I think, Madan, I can welcome the guest of honor.
Yes.
Can we have the CV for the first guest of honor, please? We are very happy that, we have collaboration of all the three committees of AMOGs, and we, in fact, quite frequently are, collaborating our programs, and we are very happy to have all of you on board. Dr. Milind Shah, who is the at present, contesting for President FOXI, and of course I know him since when he was a Foxy chairperson for Rural Obstetric Committee, and I was an active member of his committee. And of course, he was my mentor for ISOPUB also. So without wasting much time, I think, Milind, we would like to welcome you and we'd like to listen to your precious words. Over to you, Milind, for your words. We can stop sharing here. Please unmute yourself.
Yes, yes. Thank you very much, Dr. Sneha, for all those kind words. But always and always appreciated the enthusiasm you and Dr. Madan Kamble has, and always, keep on appreciating about it. That's how the AMOX is. And that's why I'm really proud of the entire AMOX committees, AMOX members, and Dr. Kiran Kartukoti and Dr. Bipin Pandit have put a lot of actually the grace in these particular positions as Dr. Rajendra has done in last year. And that's why I always feel very proud to be here to attend this particular webinar as well. And I can see the Meenal, yes, she's again working very untiring way for the welfare of the women, and that's really important. Also, to have so many friends of mine, Dr. Mitra is there. There are so many others like Dr. Shailaja and Dr. Snehanjali. And suppose I will take the name, it will take a lot of time. But basically, what I understood that all these societies work together, and that's very important. So, congratulations to the all the societies, the Mirror Society, Aklus Society, Karad, Satara, and Ichalkaranji, and the respective president and secretaries for adding actually a lot of efforts to convey this knowledge, which is very important. So, congratulations, Dr. Veena, Dr. Shilpa, Dr. Preeti, Dr. Vidya, Dr. Surya Kumar, Dr. Sanjay, Dr. Kavita, Revati, Mandar, and Arushi as well. Yeah, I was speaking with all of them, and I realized that a lot of things can be changed actually in the clinical practice. Suppose we work on this very important topic today. The unconsummated marriage, the teenage pregnancy, adolescent contraception are the important topics we need to address. While working under the aegis of FAOPS, ISOPAB, ISPAT, I realized that we need to concentrate on this adolescent health, sexual health, and as well as the emergency obstetric. And all these committees are doing wonderful work with the flag of AMOX. So I'm very sure the talks which we are going to have today by Dr. Madan, Dr. Sneha, and Dr. Minal will be definitely useful to all our delegates who are going to log in and listen to it. And even the recording will be available actually, suppose if at all they miss it. But I wish every success for this webinar. And once again, congratulations to you, Dr. Sneha, Dr. Madan, for bringing all of them together for this webinar. So all the best, and without wasting much time between the speakers and the delegates, let me request the Sneha to invite my another close friend, Dr. Rajendra Singh, for his remarks. Thank you very much.
Thank you, Mandy. Thank you so much. Can we have, yeah, sir. So
It's okay. Sneha, it's okay. We can skip that.
I can just say one sentence. Yes, you can stop sharing. You can stop sharing. Corona, the tech person. Sir is my mentor in Foxy as well as AMOX, and he's a very gentle human being, I would say, very genuine and good from by heart. So I would like to listen to your precious words, and of course have your blessings for all of us. Over to you.
Good evening, everybody. Respected Chief Guest Dr. Kiran Kurtukoti sir, Dr. Milind Shah sir, Dr. Bipin Pandit, and AMOX office bearers, and our special guest Dr. Mitra Saxena. First, I wish to congratulate Dr. Sneha Bhoyar, Dr. Madan Kamble, Dr. Meenal Chidgupkar for organizing such an academic feast on teenage pregnancy, adolescent contraception, and unconsummated marriage. As Dr. Milind Shah told, he was right. They are very important in day-to-day practice. Of course, credit goes to the organizing societies also, like Satara, Meerut, Karad, Aklus, and Ichalkaranji for their active participation in this webinar. So, with the galaxy of speakers like Dr. Sneha Bhoyar, Dr. Meenal Chidgupkar, Dr. Madan, and chairpersons. I think this is going to be a great webinar. I wish every success to all the contestants in their Foxy elections and wishing every success to this webinar. Jai Sri Ram.
So nice. Thank you, sir. And hello,
Thank you very
everybody.
much. Thank you, Rajendra.
Good
Thank
evening.
Hi,
you.
Supriya. How are you?
Hi, very well.
Over to you, Madan, for the further proceedings.
Yes, I think, yes, Dr. Minal,
Yes.
can we have inauguration now? Mehul, please share the screen.
Oh. I think
Lamp lightning.
Yeah.
Yes.
Now we will be starting our first lecture by Dr. Madan Kamble.
Yes. Yes, thank you once again, all the respected guests. Thank you for being with us today. Thank you. Over to you, Minal.
Thank you, Dr. Madan Kamble, sir. And I'm so happy to be a part of this wonderful webinar today, organized by the important committees of AMOGS and all the societies who have joined with us for this important session. Our chief guest, Kiran Kurtakoti, sir, and my own mentors, Dr. Milind Shah, sir, and Pardeshi, sir. I always owe to them because they are great support in my all academics as well as this AMOGS journey of a very wonderful journey of AMOGS. So now we will start our first lecture by Dr. Madan Kamble, sir. He's a very academic person with very dedication towards his work. He is doing excellent work in AMOGS, and the chairpersons for the same are Dr. Mitra Saxena, she's a past chairperson Foxy Practical Ops Committee and past president of Reverie OBGY Society, Haryana. Dr. Shailaja Kulkarni, she is a president IMA Karad Women's Wing, as well as past president of Karad OBGY Society. And Dr. Snehanjali Mahamuni, she is working at Sai Nursing Home, Satara, and she is a past secretary, Satara IMA Women's Wing, and recipient of Dr. Anandibai Joshi Award. So, we are starting a lecture from Dr. Madan Kamble, sir. He is consultant OBGYN, aesthetic gynecology and sexual health expert, chairperson AMOGS Sexual Medicine Committee, national coordinator of Foxy Sexual Health and STI Committee,
Yes.
past secretary and president of Akluz OBGY Society, recipient of Wonder AMOGSian Award, and
Yes.
he has a publication at AMOGS Focus on Sexual Health 2023.
Yeah, thank you, Dr. Minal.
Madan, can I say something?
Yes, yes, ma'am, please.
While Dr. Madan is going to start sharing his screen, I just want to make a comment that it is extremely interesting to know how the three committees are interplaying today. So on
Yeah.
one hand, we are going to have a talk on adolescent contraception. On the other, we have teenage pregnancy, both telling us that our younger generation is quite promiscuous. And counteracted, we have a very explored topic is unconsummated marriage. So imagine the paradox that on one aspect, we are going to be covering the promiscuity in the younger generation, its results. But on the other hand, we have to recognize the presence of something which can cause a lot of physical, mental, social, emotional conflicts in a couple. So much so that a woman can be actually suffering from post-traumatic stress disorder. And I want to thank you, Dr. Madan Kamble, for inviting me, because always when you do that, I always sit till the end, because I find that your webinars are very informative, very educative. So I'm waiting to listen to your talk and all the other talks. Wish you all the best. Thank you to AMOGS, Dr. Kiran, Dr. Vipin, Dr. Rajendra Singh, and Dr. Milind, all the seniors and stars of AMOGS. And it's like really, I thank you all from the bottom of my heart for being so hospitable to me from Haryana. And yes, it's not Revdi, it's Rewadi.
Rewadi.
Sorry, ma'am.
It's okay, it's okay,
Yeah.
I know.
Yeah.
Yeah.
So carry
So,
on, carry on.
yeah, in continuation with Mitra's, description, I would just say see the three different committees: sexual dysfunction treated by Madan, coming through teenage pregnancy, and the girl going adolescent, and then you land up into these problems of, no, I would not say promiscuous, but it is sexual liberalization. So go ahead, Madan.
Yes. Thank you, Mitra ma'am, for your kind words. Thank you. Yeah, is it full screen?
Yes.
Yes, yes, very nice.
Okay. Yeah. Good evening once again, everyone. We have purposefully selected this topic because this is a very sensitive issue nowadays we are facing. Everyone is seeing or facing this type of problems in our routine gynec practice. But many of us has very little knowledge and regarding the idea regarding the how to manage such cases, how to face such cases. But it as being a very private and sensitive issue, many people doesn't come forward, and the actual prevalence is hidden. How many cases are there? Let us understand this subject in the aspects of prevalence and some factors contributing to this, and diagnosis and management. Let us first understand what is consummation. It is nothing but to bring to completion or fruition, and to complete, this is the gross definition, to complete with the first act of sexual intercourse after the marriage ceremony, and or to fulfill, especially by intercourse. That is the meaning of consummation. Why unconsummation occurs, or why some people are unable to consummate? They may be ignorant and inhibited about the sexuality, and sometimes either of them might have had experience of coitus with another mate successfully, but after marriage they are unable to perform with their own spouse. We cannot deny this fact because many people may have the experience of premarital sex. We cannot deny this fact. Usually in our culture, husband and wife may not have any experience in penetrative intercourse before marriage. This is the ideal statement, but we all know what is the current scenario. Then let us go to the definition of unconsummated marriage. It is defined as the inability of a couple to engage in successful sexual intercourse at the beginning of their marriage, especially in the initial few nights. And in this situation, the first sexual intercourse may be delayed for years or may never happen at all. This fact is also correct. We are coming across many patients who, after the married life of 2 years, 5 years, they have not established their sexual relationship at all. This is the fact in the today's scenario also. While medical and therapeutic intervention is available, many people still suffer in silence and feel embarrassed about their condition. In spite of being highly educated or in living in metro cities, still people doesn't come forward in many cases. So these cases remain hidden. But nowadays, and this is now this responsibility lies on us as a gynecologist or as a medical practitioner to create and spread the awareness about the sexual dysfunctions and the treatments available. This is our responsibility. This unconsummated marriage can have the detrimental effects on the psyche of the individual partners. And of course, it can lead to the low self-esteem in the individuals. Again, the blame games can result in frequent fights among the partners, among the family, both the families also. And in many cases, it may lead to extramarital affairs too. Also, in a place like India, predominantly not being able to conceive and give birth to a child, there is frustration, depression, and if appropriate help is not available, it may lead to annulment of marriage and divorce. This is also a correct fact in the society. Then where does the problem lie? The problem with the sexual functioning in one or both the partners in a couple can prevent the intercourse, and here is the problem. Unconsummated marriage is devastating condition with grave consequences for the couples and families. And let us understand what is the prevalence of this problem, or what is the magnitude of this problem in the society. The prevalence of unconsummated marriage is challenging to determine accurately due to the private and sensitive nature of the issue. Yes, it is absolutely right that this issue is very private and sensitive, and that is why the actual prevalence is very difficult to determine. Many studies have been done in this regard, and they have reported the prevalence ranging from 77 to 63% in the different societies. One of the study is shown here regarding these sexual problems in patients. The sexual problems accounts for 58%, unconsummated marriage is accounting for 17%, infertility in 14%, and some marital discord in 11%. This is very worrisome situation. Then which are the factors contributing to this unconsummated marriage? This is very important to know for us. As far as the females are concerned, there is vaginal penetration phobia. There may be vaginismus, that is involuntary tightening of the vagina, which prevents the entry of penis into the vagina, or penis, not only penis or any object. That is vaginismus. Dyspareunia means the painful intercourse is there. Again, in females also, there may be low sexual desire. These are the factors as regards the females. In males, there may be premature ejaculation, there may be erectile dysfunction, there may be low sexual desire. Some physical problems like spinal cord injury may be there, high cholesterol levels, hypertension, diabetes, habits of smoking, alcoholism may be there. In some psychological factors, like some religious factors are there, some cultural issues are there. Many psychological factors are there contributing to this situation. One important cause may be there is lack of sufficient sexual information. So people more rely on this social media, or they Google for this to taking the information, and they may get the wrong or incomplete information. There are so many myths and misconceptions about the sexual practices, about their genitalia, size of the genitalia, functions of genitalia, appearance of genitalia. Then there may be sexual performance anxiety in many people. Lack of privacy may be there. And one of the important entity is there may be history of sexual abuse in the past, or in childhood, or in the adulthood maybe. There may be strict religious rules, or some sexual limitations may be there. All these can cause unconsummated marriage. Then how to diagnose such cases when such patients come across in our OPD? There should be thorough assessment of couple's sexual history. Couple sexual history means we have to take the history of detailed history of male partner, detailed history of female partner, about their sexual practices, sexual orientation, any sexual issues regarding the desire, orgasm, or any pain disorders. We have to go into details. Then thorough assessment of their physical health of both the partners, whether there is any physical problem. And third, but very important, is to know the assessment of psychological factors, because these are the psychological factors contribute majorly to these sexual dysfunctions. Then about the female evaluation, most important is the basic is the gynecological examination. What is this for? This assesses the vaginal tropism and the condition of the hymen, whether it is tough hymen, imperforated hymen. There may be any physical abnormalities or any vaginal septum may be there, or conditions that may contribute to the sexual pain or discomfort. Second is the dyspareunia diagnostic criteria. Dyspareunia means recurrent or persistent genital pain during the sexual intercourse. And these defining criteria are, according to the DSM-5 criteria, there must be marked distress or interpersonal difficulty caused by the pain, leading to the avoidance of sexual experiences or disruption of existing sexual relationship. And again, third is the vaginismus diagnostic criteria. Vaginismus means recurrent or persistent involuntary spasm of musculature of the outer third of the vagina that hinders the sexual intercourse. Again, here the important and must criteria are there should be marked distress or interpersonal difficulty caused by this condition. Then the physical examination is necessary. During the physical examination, our aim should be to identify any physical conditions or any anatomical abnormalities that could affect the sexual intercourse. And it involves the assessment of genital health and the function of both the partners. Then important is the psychological assessment. For that, an experienced psychologist and psychiatrist is very much necessary. Evaluating the psychological factors which contribute to this unconsummated marriage situation, the most important are the anxiety, trauma, any past experience of sexual abuse, or any relationship issues between the partners. And some counseling sessions may be required to explore emotional and psychological barriers to the sexual intimacy, because there are so many emotional problems or any psychological barriers that are going to affect the sexual intimacy between the partners. Then how to manage such cases? There are two main pillars of the management. One is the non-pharmacological treatment and second is the pharmacological treatment. But what I suppose is non-pharmacological treatment is very important and that contributes the major part of the treatment. First is the sex therapy. Sex therapy is the broad umbrella term. It involves many things. For example, counseling is there. In counseling, taking the history, then examination, teaching them the anatomy and physiology of the reproductive organs, then assessment of their psychological barriers, with the aim to improve the communication and enhance the sexual intimacy. Our final aim should be to improve the communication, because the communication is the key in every relationship. That I think everyone agrees for this. And as far as the treatment of the sexual dysfunction is concerned, developing or creating good communication or healthy communication between the partners is very much important, and that is going to enhance the sexual intimacy between them. The second is the cognitive behavioral therapy, CBT. This is the specific therapy. What is the aim of this therapy? In such patients who are psychologically disturbed or is there any problem, psychological problem, there are some negative thoughts or negative thought patterns or negative behaviors in such people, and our aim should be to identify these negative thoughts or negative thought patterns and modify these negative thoughts to positive thoughts, and these negative behaviors to positive behaviors which are related to the sexual intimacy. And this is very important to build the confidence between them and to create and increase the sexual intimacy. That is the role of this cognitive behavioral therapy. Then sense and focus. This is also important technique. It is the technique developed to engage in non-sexual touching and gradually progress to the sexual intimacy. To start with, there is non-sexual touching exercises, and with the aim to gradually progress to sexual intimacy and that is going to help to reduce the anxiety between the partners, and that will help to build the trust between the partners. Communication and relationship counseling, that is again very important. As I said previously, communication is the key of any healthy relationship. And couples can work on improving communication. There should be open communication between the partners, which will help in resolving the conflicts between them, and that is going to strengthen their emotional bond, which is very much necessary for this sexual intimacy or relationship. Again, one important part of treatment is education and skill building. Education means learning about the sexual anatomy, physiology, some techniques, and exploring the sexual preferences that can help the partners develop the confidence and overcome the obstacles. Because the lack of education or incomplete education or knowledge regarding the sexual anatomy that is creating so much of problem in the society and in the sexual relationship. That is why it's our role or our responsibility is to educate them. And this education can reduce the occurrence of these myths and misconceptions about the sexual practices. And some relaxation techniques are there. There are strategies such as deep breathing, mindfulness, or relaxation exercises can help in reducing the anxiety between them and promote a more relaxed state during the sexual encounters. Now let us understand about the pharmacological treatment, which options are available for this. In cases of erectile dysfunction, we are having PDE5 inhibitors like sildenafil, tadalafil, vardenafil. These are openly or freely available in the Indian markets, and many drugs are available over the counter also. People are using it. Some hormone therapies are very useful, like testosterone supplements are there. Testosterone is also available in the tablets or in the patches. Or estrogen supplements are also available in the form of vaginal creams, rings, or tablets also. And as far as the sexual desire disorders are concerned, there are drugs like clemencerin, which are used for this improvement in the sexual desire. This is the only FDA-approved drug available in India for the sexual desire. And some supportive treatments we should give in the first visit. In case of the pain disorders, we can use the lubricants or moisturizers, which can give the symptomatic relief in the sexual pain disorders. And these lubricants are available in the water-based or silicone-based lubricants. Let us discuss another aspect of this condition, that is medico-legal aspect. Yes, there are issues, medico-legal issues, as far as this unconsummation is concerned. This is again a serious issue as far as the marriages are concerned. Unconsummated marriages can vary depending on the jurisdiction and specific circumstances involved. Then how these considerations are. An unconsummated marriage can be a ground for annulment or divorce in certain legal systems and depending on the fulfillment of marital obligations. Some procedures and requirements for annulment or divorce differ among the jurisdictions, that again necessitate the consultation with a knowledgeable legal professional in family law. That is why we should have some basic knowledge about this, and if we need to consult with any specialist or any lawyer, we should or that couple should consult some official legal professional in this regard. And which medical legal documents may be necessary in such situations? Medical legal documentation may be required to substantiate claims or provide the evidence which is required in the court of law. This may involve the medical examinations, assessments. Assessments means physical assessment, psychological assessment may be there, and the reports are necessary from the healthcare professionals which are specialized in the sexual health. Maybe he may be psychiatrist also, or he may be specialized person in the relevant field, which is permitted by law. There is one Telugu movie on unconsummated marriage. That is Pelano Kothalu. It is available in Telugu. Let us summarize this situation. And the current competitive lifestyle, our working couples are under constant tremendous work pressure to meet the deadlines, leading to excessive mental stress and fatigue. And actually speaking, they are available for each other at the weekends only. And if at the weekend, if one of them is busy in the maybe having in the different work schedule, at time may not be matching, it is really very difficult to spend time together. And this is really happening when husband and wife or both the partners are working. This results in no mood tonight. Sometimes I have had a hard day. I want to sleep. I'm very much tired. I have to complete my project and get back to work early. There are so many excuses in these situations, and that affect their sex life. And this, again, it is having a bad impact on sexual performance. And their sexual performance anxiety goes on increasing. And due to this repeated avoidance of sexual behavior, and partners may enter in a vicious cycle where they may lose the sexual interest altogether, and the severity of dysfunction increases. Unconsummated marriage involves the failure to engage in sexual intercourse in the early stages of marriage. And the diagnosis includes assessing the physical, psychological, and relational factors through the medical examination, hormonal evaluations, and psychological assessments. Some non-pharmacological approaches we discuss. These are the sex therapy, counseling, and education about the sexual anatomy, physiology, and misconceptions. Some pharmacological treatments involves the lubricants, hormone therapies, and the medications for sexual desire disorders. And some medical legal considerations to encompass are the consent, coercion, and about the mental health and documentation from healthcare professionals. And these all these points are very much important, and we should understand to know whenever we are facing such situations, or as a gynecologist, as we are practicing the infertility and the gynae, everyone from us are facing day by day such situations, and we should know the basics, at least primarily what we should do, and which cases are to be referred to the specialist. Yes. Thank you for patient listening.
I think it was really very, very eye-opening, and you touched almost every aspect. I must congratulate you, because I think open communication, sometimes patients will not come and address this directly. So I think by attending to your lecture, we as gynecologists can actually recognize some telltale signs, and we can ask them direct questions as well. And maybe such couples need more of hand holding and counseling, and maybe we are not totally appropriate persons, but with all our experience we can be guiding them. I think I congratulate you, Dr. Madan, to take up very difficult topics and make them very informative and complete. Thank you so much.
Thank you, ma'am, for your kind inputs and words. Thank you, ma'am.
In my opinion,
Yeah,
the
congratulations,
person
Dr.
who is
Madan.
working for this committee so dedicatedly, I wish you all the best, that you should lead.
Thank you, ma'am. Yeah.
Yes.
Yes.
Congratulations, Dr. Madan. It was a very nice presentation as usual and as expected from you. Also, sometimes the couples don't have knowledge of the exact positioning. You know, sometimes they have intercourse between the thighs or all such and abnormal places of intercourse. So that may also be one of the reasons. So we have to teach them also. Sometimes we have to have show them properly also. Bring the husband into the examination room and show them exactly what and where he should do. Only instead of explaining to the wife. Congratulations once again.
Yes, thank you, ma'am. Yeah, you have rightly said, ma'am. You have rightly said. This is the reality, and in spite of being highly educated, many couples are lacking this information, and we should be able to address this well.
Madan sir, I again congratulate you. Actually, you deliver such a wonderful lecture. I want to add one point actually. So, in homosexual persons who actually get married because of only social pressure and only wife or husband, whoever there is, they understand the actual problem. So, in such a scenario, they have the same problem, that unconsummated marriage, but because of a social prestige issue, they even can't share the problem.
Yes, yes, sure. I agree. Totally agree. Yes, thank you. Thank you, ma'am, for joining.
Thank you,
Yes.
sir.
Yes.
Actually, the role of a gynecologist is so important to cement a relationship or, counsel them accordingly. So I think it's really a good lecture. Thank you for your comments.
Madan, can I have a small comment?
Yes, sir. Please. Yes. Please.
Yeah,
Welcome.
in fact, I was really impressed by the comments by all chairpersons and what Shailaja, what Snehanjali and Dr. Mitra told is, we have seen these patients. Like what Dr. Shailaja says, intercruris, that is the sexual intercourse between the thighs, is very commonly seen in many of the IT, actually the couples, because they don't know about the sexual practice. And then we need to teach them. We keep the set of dilator where we take them in the theater, we show them that what exactly the coital function is all about. We show some pictures also, and then we teach them. And the second point, which Dr. Snehanjali says, is again very true. Many actually such couples are coming nowadays where there is homosexuality, whether the female is not interested in male or male is not interested in female, and those they differ from the doing intercourse. And then we need to, take that history with lot of clinical acumen. We'll have to speak a lot. What I have done, I have appointed a certified counselor in my clinic. She has done her PG diploma of counseling from the Symbiosis University of Pune, and then that makes a major difference to come out with that particular causes. Otherwise, they always tell that the same thing what everyone says, ki the pressure work, I'm going to Beijing, I'm going to Germany, I'm going to do after coming back and all those things. The reason behind is something different as well. So it's very important, and you have covered all those aspects very well, Madan. Congratulations. Yeah.
Yes.
One
Thank
topic,
you.
sir. Nowadays, like many youngsters are seeing that pawns, and they have many fantasy about the pawn, the scene shown in pawn movies. But the female partner is not that much aggressive or adjustable to that things. So that might be one of the reason, actually.
I think very right, Dr. Snehanjali. Their expectations and reality is mismatched, and then
They
they
are not.
develop this inhibition. The male will have importance, the female will have vaginismus, and it backfires from the day one.
Yes, yes, ma'am. Yes.
But I must congratulate you, to speak about these things. We of our generation are also not so, like I incorrectly said promiscuous, and Sneha corrected me. But we have to change our mindset. But we have to recognize that it is there in the couples.
Yes.
Yes.
May I have?
Yes, yes, Dr. Surya Kumar.
Hello, Dr.
Yeah,
Surya Kumar.
today in this month only we come across one case of this type of unconsummated marriage for 10 years. She
Oh.
came for treatment of infertility. Then I go for a vaginal examination and found out that hymen was not torn also. And she
Okay.
had the fear factor so much that after I done hymenotomy and then I go for counseling of both couple, because the male partner also we have to take into consideration appropriately, and his any physical problem like other diabetes, impotence, erectile dysfunction, we have to be evaluated. So we found out that partner also having diabetes and he had erectile dysfunction also. So then I advise him, both couple, that they should think about further now, because almost their age is about 38-40, both couple. So we have to think aggressively in these cases, and might a few cases we require to counsel about IUI also.
Nice case. Again, counseling and physical examination. Yes.
everybody is making a comment, I would also like to make a quick, just like
Yes.
Dr. Khandare described, similar, not similar profile. She was married for 3 years, unconsummated marriage, tight hymen. I advised that bring husband, I will give counseling, then we'll go for hymenotomy. Just to save money or I don't know what, they went to some corner GP hospital, got the hymenotomy done. 6 months since that, again she came back to my OPD. She is in the same condition. Now the hymen is physically opened, but mentally it is closed because
Oh.
there was no counseling, nothing. See, in these hospital run by unqualified people, somebody is coming, operating and going. They are not concerned about long-term follow-up. They have to be advised to use dilators or to use lignocaine jelly. You do it with finger dilatation. Nothing was given, and now she's having little bit of cicatrization there, and patient is still not able to have sex. So this is the other end of the spectrum. So where one of all the esteemed chairperson said mental health and mental counseling has to be also given lot of importance, and post-op management in such cases is very important because many a time we take for granted, but people are very ignorant about the general act of sex even.
Yes, yes, you are very true. That is why counseling and education is very important, as every gynecologist should do. Yes. Thank you. Let us go ahead to the second session. Thank you once again, all the chairpersons. Yes. In our second session, the speaker for this is our own Dr. Sneha Buyar ma'am. The topic is teenage pregnancy. The chairpersons for this session are Dr. Amit Chopde, who is the clinical secretary currently of OBGYN Society of Akluz and director of Chopde Hospital, Temburni. Dr. Kavita Kamble, who is a good friend of mine. He is currently secretary of Akluz Society and IVF consultant at Karmala. And Dr. Arushi Kazwe, who is the currently secretary of Ichalkaranji OBGYN Society. I welcome all the chairpersons, and I request Dr. Arushi to introduce Dr. Sneha ma'am. Over to him. Yes. Is there Dr. Arushi ma'am? I think
Arushi, I can see, but she's, I don't know, traveling or what. Otherwise,
Ma'am,
Kavita.
please unmute. Ma'am, please unmute.
Good evening, everyone.
Yes, good evening.
It's a great opportunity for me to introduce Dr. Sneha. Just around 15 days ago, I met her. She's a very eminent personality. And she has done her MBBS and MD both from BJMC and Sassoon General Hospital, Pune, and managing director of Sukhartha Hospital, Maternity Surgical Nursing Home, Laparoscopic and Infertility Center. And she has 32 years of experience in this field. Of 5 years in SVN Government College, Yavatmal. She's our candidate for Vice President Foxy West Zone for the upcoming election 2025-26. And she has more than 300 talks in state, national, and international conferences, and 25 articles, chapters in national publications. She's a peer reviewer in Jogi, and she has won many awards and accolades, such as National Faculty of HPV, Master's Trainer and State Coordinator, IMA Maharashtra, National Individual Award by Foxy 2008, Dr. Anandibai Joshi Award by Government of Maharashtra 2005, National Adolescent Trainer, Foxy President Application Award for Public Awareness 2016, Foxy President Appreciation Award for Exemplary Work in Cancer, WOW 2019, Champions of Foxy 2019, International MS Signature Award
Thank you, Dr.
for
Arushi.
phenomenal
Thank you so much.
leadership. Thank you, ma'am.
Thank you so
Yes.
much. Yeah, can I share my screen? Yeah, thank you so much. In fact, apart from that, those 5 national awards by Foxy and 3 by Government of Maharashtra, I would just like to introduce myself as hardworking, hardcore obstetrician. I think that will be a better introduction for me. So thank you so much. I'm one amongst you. I would just like to share my screen and go ahead with the topic for today's, that is little different, much discussed, the teenage pregnancy. Though all of us, as an obstetrician, we always say that teenage pregnancy is a high risk pregnancy. I think that's the only description and discussion we have about this aspect. So that's the reason I've chosen this topic. I think, it is quite disheartening to see this picture, these young girls having pregnancy in their age, very sensitive, tender age of, building their career and their life. So teenage pregnancy, that means pregnancy before achieving 20s, that is between 13 to 19, that is what it is described. But it can be even defined as achieving pregnancy or having pregnancy before reaching the legal adulthood. And this actually varies from country to country across the world. So this will be different age groups. Almost half of this world's population, they're under 25 years. So we have maximum young population, some around 1.8 billions. They are, between the ages of 10 to 25 years. And this is actually history's largest generation of adolescents. About 85% of these, they live in the developing country. So most of these people, they become sexually active before their 20th birthday, and that's a ground reality what we have to accept. Almost 49% of these girls in the least developed countries marry before they turn 18. So it doesn't mean that teenage pregnancy means unmarried girl with pregnancy. It can be married young girl with pregnancy as well. So 10% to 40% of these young unmarried girls, they have had an unintended pregnancy according to the community studies. And almost 14 million children worldwide, they are born to these young married as well as unmarried women before the age of 15 to 19 years. So before the age of 20 years. So what is this social perspective of this sex revolution, we would say? It actually started in 1960s, and Alfred Krishney, this was a study, and there comes the concept of invention of birth control pill, separation of sex as well as reproduction, because before 1960s, the relation of sex only was, the main aim was to have reproduction, to reproduce for the human species. That is what was the concept of sex and pleasure came huge after 1960s. So and of course the OC pills got birth then only. So what are the causes for this young or teenage pregnancies? Basically the child marriages, which is the major drawback, we can say, for our society, where even today, in spite of all the laws and rules and regulation, women are, or the girls are getting married even before, achieving even menarche. That is also, we can say. So early marriages, adolescent sexual behavior, because of this, under the substance abuse, that is alcohol and drugs, and lack of sexual, I would not say sex education, sexuality education, that's a better word for this. And peer pressure, because most of the friends, they are having their girlfriend, boyfriend. So if somebody doesn't have, she gets pressurized, and that's the very reason she also adopts the same thing. Sexual abuse, rape, this is a very common situation. Poverty, maybe the sex workers, we can have those sex workers promoting their girls again in the same, what you say, same profession, or maybe in the misabuse, you can say. Exposure to abuse, violence, and family strife at home. So if the parents are having disharmony, marital disharmony, if there is violence in the family, the children feel neglected and they resort to such sorts of wrong friendship, we can say. Low self-esteem, desperation, somebody is not good looking and she's being criticized, so she tends to have a boyfriend, and that also can culminate into a sexual relationship. Low self-esteem, desperation, and low educational ambitions and goals can also be the reason for this. What is the impact? The impact can be physical, as you all know that teenage pregnancy itself is a big risk factor. Psychological impact, and then of course the impact on the socio-economic status. So psychological impact, of course, this young girl who is yet not psychologically mature, not able to handle her own emotions, naturally she is not capable of handling this pregnancy and the associated problems as well. So having the feeling of guilty, she may have a dropout from the school, resulting into poor education qualification, and then of course the unemployment, and she may live in poor housing conditions, may suffer from depression for all these situations, and then of course that will affect her life or maybe her welfare as well. The children who are born to this psychosocially affected woman definitely will also suffer because of this. So the children, they live in poverty, they grow up without a father or a family, they become the victim of neglect or abuse, and they, of course, either they may not go to school, or if at all they go, they perform poor in the schools, become involved in criminal activities, maybe even the substance abuse, and eventually they also become the teenage parent and begin the vicious cycle continues. What is the medical impact or the physical impacts? What I said, research indicates that the pregnant teens are less likely to receive prenatal care. Basically, they may not identify or recognize that they have become pregnant. Maybe they recognize it a little later, and that's a very reason they may not resort to the antenatal care. The fear factor may be one of the reasons, and the stigma, of course. As a result of insufficient or inadequate prenatal care, the global incidence of preterm birth as well as low birth weight babies is higher among the teenage pregnancies. Risk of medical complication. The girl who is growing, she has to fulfill her own nutritional requirements, and this additional burden of pregnancy is put on. So already pre-existing anemia can worsen. She may land up into very severe anemia. And then all of you know that teenage, the extremes of age group, less than 18 years, they are more prone for development of hypertensive disorders of pregnancy. So that is also one more reason. And then we have talked about the low birth weight baby, that is small for gestational age feti, or even the preterm labor or preterm delivery she can land up into. The girl who is growing, pelvis may be very contracted, and here at this point of time she may land up into complications of prolonged obstructed labor, maybe even operative interventions, and if left unrecognized, she can land up into traumatic delivery and then the fistulae, which can spoil her life. Complications during pregnancy and delivery are the leading causes of death. You can see the statistics between 15 to 19 years of age. The risk of maternal death is twice as high, if you compare to the birth of women for in 20s. So after 20s, the incidence becomes less. Teenage girls account for almost 14% of the estimated 20 million unsafe abortions. So unsafe abortion and resulting mortality also can be the problem for these girls. What is the impact on her physique? The long-term complications, especially the sexually transmitted infections, HIV, AIDS, and other things. So as a result of unprotected sex, these young girls are also at a risk of sexually transmitted infections and HIV. So the highest rate of STIs worldwide among the young people is 15 to 24. almost 5 lakh become infected daily. That is what, excluding HIV. We are not talking about HIV. The incidence for HIV is different. 2 in 5 new HIV infections, they are in the young adolescent or young teenage pregnancies. Okay, so young girls who are pregnant, of the 5 HIV positive people, 2 are the youngsters. Okay, so surveys from 40 countries show that more than half of the young people, they have misconceptions about how HIV is transmitted, because they're not aware about it. Married adolescent girls, generally they are unable to negotiate condom use or to refuse sexual relations, and they are often married to older men with more sexual experience, which puts them at a risk of contacting STIs, including HIV. Now, how can you prevent all this? Definitely, the factors which are the causative etiology, we have to work on that. So, sexuality education and counseling, that is the most important aspect, I would say. Sexuality education and counseling. Yes, here also, when we talk about adolescent clinics, the first line every time is, don't be judgmental. Don't teach them moral values that before marriage you cannot have sex and all these things, because this is a society where absolutely you have to be non-judgmental, and here everybody is much aware about their sexual rights as well. So what you have to say, it is better not to have intercourse before marriage, but if at all you are, or maybe you are likely to have, please protect yourself. So your protection will lead to, that will help you from both the aspects. It will save you from having sexually transmitted infections as well as the unwanted pregnancy. So that is what is the counseling part of it. Religious morals and ethics, I told you that we can't be judgmental and we can't advise them, but yes, you can just test her and you may just advise her. Safe sex and use of contraceptives, definitely I have talked to you about this. Abstinence amongst teens cannot force, you can just suggest. Prevention programs and role of parents, schools, religious institutions, of course, you have to take all of them into consideration, and it will be like a in combination, you can have the combined effect on the teenage girls. So in Malaysia, they have, family planning in young people challenges, what challenges they are facing. But then basically many societies, including Malaysia, they disapprove premarital sex. So as a result, these young people, they have limited or no access to education and information regarding the reproductive sexual health care. Modern contraceptive use among adolescents is generally low and it decreases with the socioeconomic status. Fewer than 5% of these poorest young use modern contraception. So young women consistently report less contraceptive usage than men, and evidence of their unequal power in negotiating safer sex or restriction on their access to services. Young people may also, hesitate. Even if you have adolescent health clinics, the young girls are the ones who are very hesitant. Even for their menstrual problems, they cannot, they don't want to visit the gynecologist, thinking that, what people will think, that whether they have come for some other advice, or maybe they have come for some sexual problems or contraception or pregnancy. And that's a very reason all these myths and taboos can worsen the situation. Laws and policy may restrict the adolescent access to information and services, for example, by limiting the family planning to married people, or requiring parental or spouse consent. So all these problems, so there should be basic, there should be advocacy that should be in favor of these adolescents. That is what is the need of the hour. So you can have, these are just the examples how the teenage pregnancies, they are in Western countries, how they can report themselves and they can face themselves. This is, I think, 13-year-old boy facing the, facing the pregnancy. I mean, he's a father at the age of 13 years. These are some of the examples from the Western countries. So I've talked to you about the medical impact the psychological impact and the socio-economic impact of the teenage pregnancy. So basically, only few lessons for the girls we can say, and of course the guys, you can see the 13-year small boy, becoming a father. So when a guy says, let's have sex, have courage to say no. I would say have courage to say no, basically. Before this, I would just say having sexuality education, what is the act and what are the problems and how to protect yourself from the intercourse as well as from the STIs and the pregnancy, that it needs to be taught to these young adolescent girls and boys, as I already said. Avoid being alone with the guy, especially in the dark places or the house alone. Make sure your parent is there in the house. Avoid being intoxicated or unconscious. As I have already talked to you, that peer pressure is the most important factor in the era of today's, in today's era. So peer pressure, we have to avoid, have good company, and see to it that you don't have anything which actually the your peers can intoxicate you or make you unconscious. So cultivate good circle of friends, that is the important message, and practice abstinence. Wait for marriage. I don't know how much you can say this and how much people can accept it. So that is a bit, a question mark here. So with this, I end my short talk and I hand over to you. I just thank all of you for the patient listening. And I just use this opportunity to humbly seek all the respected seniors' blessings and all of your vote and support for my candidature as Foxy Vice President from West Zone. You know that there are 2 posts. Please make me as your priority candidate and vote in maximum number. That is your right to select your representative to Foxy. Thank you so much once again. And over to you, Dr. Meenal, for further proceedings. Thank you so much, Madan, for that.
Yes. Thank you, ma'am. It was a wonderful presentation. I request the chairpersons to give their inputs. Yes.
Yes, good
Kavita.
evening. Yes, good evening, everyone. I'm Dr. Kavita. Ma'am, it is indeed a pleasure to listen to you and your words, and you have aptly covered the topic, emphasizing that poverty and poor education are the main cause for teenage pregnancy, as well as the girl being unaware of the things or the complications that can occur being with a boy in dark places. So this awareness of sexual awareness should be prioritized by going to schools and making them aware of this. That's how we can prevent unmarried teenage pregnancies. But the problem now is that we have patients who have altered their age, come with 18 years, and then they pose like they are a teenage, but they pose their age as more than 20. So I have a question: how do we handle such patients, ma'am? Because they know that they are now not supposed to be married before 18, and then they pose like they come with their even their Aadhaar card is changed, and it becomes very difficult. We know that they are young, but they pose themselves as more than 18 and 19 or around. So I have, like, in rural areas where I practice, this is such a common practice. Sometimes it's become very difficult to understand, or how do we negotiate, or how do we go about such cases?
So basically, at the beginning of the talk itself, I have clarified that teenage pregnancy doesn't mean unmarried young girls' pregnancy. It is the age of pregnancy or age of the girl less than 20 years. Basically, it is, you can say less than 18 years, because for our country, the legal age of adulthood is 18 years. Okay, so married as well as unmarried girl. And in fact, I said that some of our states, the age of marriage is, is even before achieving menarche. It can be even small, 2 to 5 years and even 10 years or so, they can get married, though the sexual intercourse and everything comes little later. But marriage can happen, and of course, comparatively, the sexual intercourse will be earlier. Now, coming to your query, that you are saying that, once you diagnose a pregnancy or in a girl who is less than 18 years, that becomes POXO. The POXO comes into picture. Okay. So for us, the binding is only this much, that the moment that girl who is pregnant less than 18 years comes to you, whether you as a gynecologist or even a GP who does the UPT or even a radiologist who diagnoses the pregnancy on ultrasound, it's a legal binding to all of us to report to police or to inform to police. That is the first thing. Now coming to your second, addressing your second aspect, that sometimes they are changing their Aadhaar card. So see, basically, I don't think changing the Aadhaar card is possible. Now, what you're saying is changing her identity. So for us gynecologists or obstetrician, it's only important that the patient who is coming to you, whether she is the same person. So whether her name on your record and on the Aadhaar card matches, and the date of birth on the Aadhaar card is more than 18 years. It is showing 18 years. Your responsibility is over. Okay. If it is according to the Aadhaar card, it is less than 18 years, it is your own responsibility that you have to inform to police whether the patient or the families want it or no, whether they like it or no. Right? So I think that is our moral responsibility. Now, what is the practical problem? That also I'm telling you, because I am a private practitioner throughout now. Okay, so right from the beginning, you can say, though initially for 5-6 years, I was into government medical college. But since then, for 29 years, now I'm into private practice. And this is day in and day out we have to face. That whether they like it or no, you have to inform. But if it is, even for abortion, that is whether medical or surgical, you have to only inform to police. You don't have to wait for their permission, right? But you have to take it in the writing. You have to inform to police and take it as acknowledged, received, right? You don't have to wait even for permission. You don't have to ask them for permission. It is their job whether they want to register crime or whatever they want to do. Only thing is, when you want to go ahead with abortion of this patient, you have to make sure that you collect the POCs, products of conception, in normal saline, because that, if at all they want, from you, they want to go ahead for the DNA studies. So that's the only thing I think. But once what your aspect is, your patient's name and age, what she is telling, if it matches with the Aadhaar card, records, your responsibility is over. Right. Okay.
Thank you so much, ma'am.
Thank
Yes, and best wishes from
Thank you so much.
from all of us here for the elections.
I would request all of you to please, support me wholeheartedly.
Yes, ma'am.
Thank you. Thank you
Yes.
so much. I can
Thank
see
you.
Revati also there.
Yeah.
Hello, Revati.
Yes, ma'am. Hello,
Right.
hello.
Hello.
I've been listening to the talk. I want to congratulate all the organizers that it has the webinar has been going on fantastic. And I just listened to your talk, and also Meenal is also going to talk about teenage contraception. So regarding this, what you correctly said, that the sex education, sexuality education is very important, and with Madan sir and with Meenal only, Amox PSC, we are doing this Ghe Bharari project for all teenage girls. And recently also with Foxy, Gyan Prayas, we have launched this Amox with Foxy, adolescent sex education for boys. So I feel what you pointed out correctly is making them understand and taking them, control of their lives is very important, I feel, rather than managing the complications. So wonderful talk, madam. Thank you.
Thank
Ma'am,
you, all
I
the
have one
chairpersons.
case to just, if I have 1 minute time actually.
Yeah, please.
Actually, I had one case in last year. The 13 to 14-year-old boy, like he came for complaint of repeated pain and infection at the penile side. So I examined, I took all the history. But very surprisingly, he told he was assaulted by his family member or Vahini actually. And I have taken him in confidence and asked everything about it. The first case, I think so, that was a file against that lady under the act of under the law of POCSO.
So was it filed? The case was filed.
Yes, yes, yes. Case is on court, ma'am, right now.
Okay.
But for that, like we struggle hard.
Mm-hmm. Oh, this is also possible.
Day
Right.
by day,
Yeah.
situations have become
Mm.
so
No,
so
actually, that
drastic.
was very surprising. Actually, even no one was like trusting that boy.
Mm-hmm.
So the sex education not only for girls, but it is very important for boys also.
Yeah, that is what we are saying. We are all the time saying not only girls, boys also.
Yes,
So that is,
yes, yes,
yeah, definitely.
yes, yes. Thank you, ma'am. Thank you for the wonderful topic.
Yes. Thank you.
Thank you so
Let
much,
us
all of you, for joining, and thank you so much, for all your appreciation. Thank you.
thank you. Let us move to this session number 3. Mehul. Yes. We have our own speaker, Dr. Meenal Chidgupkar, who is going to talk on adolescent contraception. And we are lucky to have the chairpersons for this session, Dr. Jyoti Rokde from Mirrors, who is the past secretary of Mirrors Society. Welcome, Dr. Jyoti. Dr. Supriya Arwari, the past secretary, Thane Ubejibai, past AMOC chairperson, national coordinator for POXI Adolescent Health Committee. Next is Dr. Surya Kumar Khandare, who is the secretary currently of Satara Ubejibai Society, past president of IMA Satara. I welcome all the chairpersons and I request Dr. Surya Kumar to introduce Dr. Meenal. Surya Kumar, are you there?
No, I don't think.
Oh,
Okay.
Aega?
Good
He's
evening.
there. He's there.
Yeah, good
Yes.
evening. I
Okay.
introduce Dr. Meenal, madam. She is the director of Dr. Chidgupkar Hospital Private Limited, Solapur. She is a senior infertility and IVF specialist at Apollo Fertility, Solapur. She has more than 12 years experience in infertility and laparoscopy. She is a pass out student of MBBS from GS Medical College, Mumbai, DNB from Sion Hospital. She has completed her diploma in infertility and laparoscopy from Kiel University, Germany. She also a fellow of reproductive medicine and advanced laparoscopy from England. She worked extensively in the field of adolescent health, pre-cancer detection, and women's health. It's now over to Dr. Meena, madam, for your nice presentation. Hello.
Meenal?
Yes, Minal, unmute yourself.
No, she's sharing.
Yeah, but then she can unmute, no problem. Make it full screen.
Go to slideshow.
I think she has some problem with internet.
I was mute.
Oh, okay.
Minal, I would suggest you to log out from one device, the one which
Yeah,
is
yeah. I have
moving here.
logged out
That
from
is
one
giving
device.
you, that is giving you echo. Yes.
Yeah. Now you can see my presentation, madam.
Yes.
Yes.
Only,
Yeah.
only make
Okay.
it full
Just
screen.
make it a
Make it
slideshow.
खाली आहे,
Slideshow.
खाली.
Okay. हाँ.
Right
खाली
side.
आहे बघा.
झाले?
Yes.
Yes.
Right.
Yeah.
Thank you so much. So today's my topic is contraception in adolescents. William Shakespeare says, "Youth is like summer morning, age like winter weather. Age, I abhor you, and youth, I adore you." So youth today has a lot of challenges, and adolescent sexuality today having a lot of problems. Like 26.8% of the students are sexually active. Boys were sexually more active than girls. Condom use was present in almost 51% of the sexually active students, and half of sexually active males have sex under the influence of pornography, and 1/3 had sex merely because of the peer pressure or the curiosity. Among girls who experience this succumb to peer pressure and under the influence of pornography. Boys and girls had knowledge about reproductive health issues, and this difference between two sexes were found to be statistically significant. So almost 70-50% people have some knowledge about reproductive health issues. So we see this contraception is the unmet need. So what are the different types and from the basket of contraception, what can be given to these adolescents? So contraception in Indian adolescents need is over 2 million adolescent girls in India have an unmet need for modern contraception. 52% of adolescents giving birth make the recommended minimum of 4 antenatal care visits. 78% abortions among adolescents are unsafe, and many adolescents do not receive needed care during that unsafe abortion. So impact is if all as adolescent women in India wanting to avoid a pregnancy were to use modern contraceptives and were provided the full spectrum of contraceptive options, counseling and information, and if all needs for maternal, newborn and abortion related healthcare were met, annually we would be having 7 lakhs fewer unintended pregnancies and 4 lakhs fewer unsafe abortions. So sexually active adolescent is more likely to seek contraception if they perceive pregnancy as a negative outcome, have long-term educational goals, are more mature, experience a pregnancy scare or actual pregnancy, have family, friends, or a clinician who sanction the use of contraception. So there are different ways of contraception, types of contraception, in that barrier contraception is very important, and barriers to the contraceptions are concerns about the confidentiality and the parental notification, cost, misperceptions about the risk of getting pregnant and the effectiveness or the contraindications, then pre-initiation evaluation or the adverse effect of contraception, knowledge deficits among adolescents and healthcare providers, and difficulty assessing contraceptions. We have observed when we are dealing with the adolescents in nearby area or our area, that girls who are actually sexually active but they have no access, direct access to doctors like gynecologists. They are doing everything according to what their peers are telling them or what accordingly is they are watching on internet or social media. So they have not proper knowledge about anything, but so they are facing lot of difficulties when it comes to starting any contraception or continuing it, and if there are any side effects of that, they are not able to understand it, and there are a lot of problems. And when it comes to coming to gynecologist, they always fear they have to come with somebody from the family, and then how to ask such questions, because it is still a stigma in our scenario. So options we have are the COCs, combined oral contraceptive, progesterone only pills, implants, injectables, even intrauterine devices can be used now in adolescents. Emergency contraception, though it is risky, but they have to know about this to avoid unwanted pregnancies and barrier contraceptions. So along with this pregnancy, the STIs or infections also can be avoided. So communication strategies are very important. Girls don't often feel a sense of control over their reproductive health. Information about long-term female-controlled methods of birth control is hard to come by, leading girls to rely on ill-informed peers or their partners for the information about their own reproductive health. Teen won't reach out first, so negative beliefs based on the rumors or myth. Contraceptive choices are confusing and intimidating. Clinics are intimidating, fear of judgment and lack of money or accessibility. Family planning is perceived as something that is only for married women. So adolescents simply assume that contraception is not meant for them. Long-term decisions are difficult to make. Teens are not accustomed of making long-term decisions or deciding anything. So counseling should be non-judgmental, unbiased, sensitive, catering to needs of adolescents and realistic information on use and failures. Actually speaking, the abstinence can be promoted as a very important method to these adolescents. It gives 100% protection from pregnancy as well as 100% protection from STI and HIV. Some recent studies demonstrated the importance of youth, parent, physician, and education partnerships for the prevention of health risk behaviors such as early initiation of sexual intercourse. Fertility awareness based methods like needs, precision, and control may not be recommended to adolescents. Majority of physicians considered natural family planning methods to be a poor option. So barrier methods, male condom, those are easy to use, cheap. Failure rates are high actually, 5 to 20 per 100 women year. Protect from the pregnancy, STI and HIV. Counseling and guidance, it is better efficacy and use. Female condoms are not easily available and needs training before use. Combined oral contraceptive pills are hormonal methods of contraception that contain both estrogen and progestin. The pregnancy rate with these methods is 4 to 7% per year in typical patients. Non-contraceptive benefits of combined hormonal contraception include improved bone density, and protection against ovarian cancer, endometrial cancer, salpingitis, ectopic pregnancies, benign breast diseases, and acne and iron deficiency. But there are certain disadvantages also and contraindications also about these oral contraceptive pills. So we have to get the complete history of that girl and then only prescribe these medications. Oral contraceptive pills, most popular method of hormonal contraception and only method that may providers and patients consider. Overcoming barriers is highlight on non-contraceptive benefits, offer extended and continuous use, think about access and privacy. All women can be of excellent OC pills use. So which pill is better for adolescents? There are many pills available in the market. We have to choose according to their physical condition and their weight and which category, PCOS, the androgen increase, and then we have to describe, tell them the various OC pills and give the exact, prescribe exactly. No pill is inherently better than the other pill. All pills contain same type of estrogen, ethylene estradiol. Differences are in the progestins, can be low dose, ultra low dose, and no difference in the efficacy also. Oral contraceptive pills, why do 24% of the adolescent never take the first pill after receiving the pack? Confusion about starting instruction, waning motivation, and become pregnant while waiting to start, or sometimes stop in the middle, and there can be breakthrough bleedings also. There are many contraindications and we know them, and we have to take the complete history before prescribing anything to the adolescents. COCs, the practice points, are the combined oral contraceptive pills require the adolescents to take the pill daily and to remember to refill their prescription. So it is very important to have all this information given to the adolescents and accordingly the treatment. So there are drospirenone pills available in the package containing 24 tablets, and negligible amount of drospirenone are secreted in the breast milk, so they are safe also. Contraceptive implants are also important. The fertility returns quickly after removal, and the unexpected and prolonged vaginal bleeding is a common side effect and can trigger request for premature removal. Contraindications can be known or suspected pregnancy, severe cirrhosis, or other problems which we have to understand when we are thinking about this kind of implants. So there are Depomed, deoxyprogesterone acetate injections also, and the pregnancy rate is 4 to 7 per year in typical patients. Return to fertility may be delayed for more than a year. it is like many girls, adolescent girls, are taking such kind of medroxyprogesterone acetate depot in adolescent age. The menstrual changes are the common side effect of DMPA and a frequent reason for discontinuation. There are many issues with DMPA also, and there are certain contraindications also we have to take into consideration. IUDs and adolescents, there are common misinterpretations. IUDs increase PID and STDs. They cause infertility. They can't be used in the nulli gravidas, and IUDs can't be used in the women with a previous ectopic pregnancy. So menarche less than 20 years, risk of expulsion due to nulliparity is there. STI is there due to sexual behavior in a younger age group. IUD can be used in adolescent girls and nulliparous women who desire long-term reversible contraception, which is told to us by the WHO 2010. So LNG IUS, that is T-shaped piece of plastic that releases small amount of levonorgestrel each day, that can also be used as a contraceptive device when there are different responsibility. Approved for 5 years of use, remove any time, immediate return to fertility. It has a good evidence in heavy bleeding and dysmenorrhea and pain, and some evidence in endometriosis, fibroids, adenomyosis, and endometrial hyperplasia. Emergency contraceptives in adolescents should have knowledge and accessibility. Counseling, 1.5 milligram of levonorgestrel single dose. Shomili, please. 1.5 milligram of levonorgestrel single dose. Efficacy 85% if taken within 24 hours of unprotected intercourse, and can be taken up to 3 days after UPI, and along it may have efficacy up to 5 days. Pregnancy risk is 1.7 to 2.6%. Dual protection is always better. Adolescent girls with risk of unplanned pregnancy and STI, HIV are frequently counseled to use hormonal contraceptive to protect against the former and condoms to protect against the later. So adding condoms is also very important. The recommendation, regardless of patient's age or the previous sexual history, the obstetrician and gynecologist routinely should address her contraceptive needs, expectation, and concerns. Status about on the rights of minors to consent to healthcare services are vary by state, and obstetrician and gynecologists should be familiar with the regulations that apply to their practice. Emergency contraception routinely should be included in discussions about contraception, including access issues. American College of Obstetrician and Gynecologists recommends that obstetrician and gynecologists write advanced prescriptions of oral emergency contraceptions for their patients. These long-acting reversible contraceptive methods have high efficacy. Discussions about contraception should begin with the information on the most effective methods first. Gynaec should be aware and prepared to address the most common misinterpretations and age-appropriate, compatible way they have to produce and give patients health literacy. Initial encounter and follow-up visits should include continual reassessment of sexual concerns, behavior, relationships, prevention strategies, and testing and treatment for sexually transmitted infections. Now, education, global research, and advocacy and capacity building is important. So, take-home message is adolescents are eligible for all contraceptives as in adults. Effective contraceptive counseling for adolescents should be a high priority for primary care provider. Contraceptive services visit include relevant history, physical examination, limited provisions of information, and anticipatory guidance about sexual behaviors. Contraceptive counseling should include abstinence as an important option. Provisions of contraceptive methods should be offered as per teenagers' choice. Education about and provision of EC is effective in reducing the rate of unintended pregnancy and abortion. Thank you.
Thank you so much, Dr. Minal. I would like to have comments from our esteemed chairpersons.
Congratulations, Minal. Very, very good presentation. very exhaustive and very well covered all the topics. And more and more teenagers are now, we know, indulging in premarital sex and teenage sex. Uh, uh, of course, I understand that this is beyond the purview of a POXO lecture, but we also need to inform the children that they, if in case one partner is less than 18 and the other is above 18, then the partner who is above 18 can be legally prosecuted under the POXO Act. And also, when we are prescribing on our paper any kind of contraceptive advice, the patient's age should be very clearly mentioned. If there is any doubt, request for a proof of age and then prescribe contraceptive advice. Otherwise, if you do not report less than 18 years under POXO Act, we will really, get stuck on the wrong side of the law. That is the only point I wish to make, because this is something that many of us come across in day-to-day life. And I know it's very easy to say and make PPTs, but when we are actually dealing with young children sitting across, and you don't know how to break it to them, ki, look, I need to now inform the police. So it's a very, very tough call, but I guess that is something that we all need to know. The
Madam,
excellent presentation.
yeah.
Congratulations.
Madam, I want to ask you, when we are prescribing contraceptive, when they are not pregnant, but we are prescribing contraceptive, is it allowed less than 18 years? Can we prescribe contraceptive for their own benefit?
See,
No,
I
I
tell you, see what the POXO Act says. The tenet of the POXO Act is that if you have a knowledge or even apprehension means they have not actually had sex, but they have come to you asking for contraceptive advice, means now they are going to have sex. So even if you have apprehension that a person less than 18 will indulge in sexual intercourse, you are supposed to inform the police. So if you want to prescribe OC pills, then the best way to do it is, on paper you write diagnosis as irregular menses, shorter cycle, long cycle, heavy menses. Make mention some complaint which can be of gynecological nature, and then you prescribe. Or you prescribe, but then you have to make a information to the local appropriate authority. So either the police station or to the juvenile magistrates area. So one of the two people you have to inform. If you are not informing, then I told you this is the via media. You write diagnosis as some gynecological complaint.
Okay.
The law will not excuse you. See, only pregnancy is not POXO. POXO is any child less than 18 years having sex, irrespective of whether they have become pregnant or not. So that is one thing you have to be very, very careful. While you, on paper, you should be perfect on that.
Right. Okay.
I
Thank you.
think
Nice
Supriya
presentation.
Yes,
raised
ma'am.
a very valid point. And I must compliment Dr. Meenal, your presentation was very good. That is the dilemma which Dr. Supriya has very much addressed, that we want to educate because we know they are going to indulge in it. But can we write and put our neck in the, noose? But I still feel that, educating them, not putting it on paper. And I personally always tell the patient, the girl, that you have to be, if you want to really indulge in sex, you have to be doubly smart. Protect yourself from infection and from pregnancy.
Yes.
So, both you have to use the best method. So, I tell them that put the responsibility of the sex on the male so that the condom is used always. Do not give the freedom to the male to know that you are using contraception.
Correct.
And on your own, you use the oral contraceptive because that's the closest that you will have with the zero failure rate. So if you are and of course, like you Supriya said, I think we have to tell the girls that if you indulge in sex before 18 years of age, you are going to be under POXO. So they have to take a call now. If they are so mature, they have to know that it can
Yes,
be
ma'am.
very
Yes,
harmful.
ma'am.
Yes,
I am
yes, madam. Very important point, because
for
we
indulging.
could have given this information and prescribed to patients, but it is very important to know the law also and to be safe from
Absolutely.
our side also.
And moment things go south, the first people that they will try to tighten the noose against is your neck. The people who are actually perpetrating will be on the side, and you will be the one who will be first in the news of the law.
The parents
Dr.
will
Meenal,
accuse you कि इसको इन्होंने फंसा दिया है या boy side या girl side. तो डॉक्टर को तो
Dr.
पता
Meenal,
नहीं.
can I add a point in this?
Yeah.
Sure,
The
sure,
point-
Jyoti ma'am.
Yes. The point was discussed about the Aadhaar card. Being in medical college every day, I tackle with 2 or 3 girls who are with POXO, or they get married before the age of 18 years and they are POXO. So the thing is, we have, and many a times Aadhaar cards, they are not considered as valid. So it is the school leaving certificate or the birth certificate
Absolutely.
is considered
Perfect.
as the proof for the document for the age, and then only we can proceed for the things. This is the point which I wanted to tell.
Absolutely. Madam, about this, we have had several discussions.
Supriya,
Aadhaar card is not considered as a proof of age in the eyes of the law. The only thing that is authentically considered is, for one is birth certificate, and second is school leaving certificate given by school, because in our times the school used to take the birth certificate original, and then in the 10th we used to get a school leaving with the birth date written. Now the main practical issue is, how many of us carry our birth certificate with us? None of us do that. So in a small clinic, if patient just comes cursorily and then we have nothing else, kuch nahi se acha Aadhaar card. Aadhaar card problem is that the date is written what you have told them. Tomorrow if I tell Aadhaar card person माझं वय 16 आहे, तर तो तेच लिहिणार. He will not ask for proof probably. So that is why Aadhaar card is not considered. But in absence of 10th standard certificate or birth certificate, Aadhaar card or even your passport or your election card with a birth date, it can be given. One thing that we can do in such circumstances is, like I'm talking about a clinic where first time patient has come. She says she is 19 years. Aadhaar card is saying 19, but we have doubt she doesn't have birth certificate. Then let her write, take a undertaking from her that my age is 19 years, this is my date of birth, and I have informed. And let her write in her handwriting, so that at least we can state in the court of law that we have taken due precaution and the patient has given false information. So that is one thing maybe where we can, save our neck. But what you said is absolutely true, ma'am.
One question I want to ask whoever will answer. What is my understanding is that if some girl gets married earlier than 18 years, then she does not come in the purview of POXO. Because
No, ma'am.
She comes.
Ma'am, POXO Act is applicable irrespective of the marital status of the girl.
No, but suppose
The only circumstances where it is not applicable is, I think there is a limit more than 8 years after marriage. After that, we don't. Now suppose patient comes to us in her 30s and she has got married in 17 years, we don't have to, because by then she is more than 8 years after marriage. Exact limit I don't remember though.
No, but what I'm trying to tell is, I think we should just find this out in more detailed view, because if it is a legal marriage, if
No,
husband...
ma'am. About this, I'm quite confident, because this has come from directly from the authorities. There, we had one talk by Dr. Shailesh Moite. He is a forensic medicine expert. Legal.
Can I add something, Madam Mitra, Madam,
Sure,
for
Jyoti,
your
ma'am.
question?
Yeah.
Please, I want to be educated.
Yes. If the girl is less than 18 years and she is married, it comes under POXO number 1. In this case, we inform the police. Police comes, and there are the cases where the husband immediately gets arrested.
Yes.
Even the in-laws, they get arrested. Then there is a DNA sampling which is mandatory for that girl, even if she refuses. And after that, once everything is over, the girl is given to the child welfare committee, irrespective of whether she is married or not married. We are concerned about married girl less than 18 years.
Yes.
Once the child welfare committee comes, the police comes, then the police statement and the case stands in the court. and then all the formalities are over, then there could be out of court settlement. That is not our purview. But the thing is, it goes under the jurisdiction of the police when the girl is even happily married with her husband and it is a lawful child with the husband. But if it is less than 18 years, it goes under POCSO.
Yes, correct.
I agree with you, but unfortunately, in our part of the country, in Haryana, the girls get married very early. But as of now, I have no case on record in the last couple of years. So I will still look into it. Thank you, ma'am, for telling us the whole sequence of event. Anyways, we should not get stuck. Thank you.
Thank you.
Thank you.
Minal.
Thank you and
Thank you, Madam.
congratulations.
Thank you.
Yes.
Thank you. Thank you.
Thank you all the chairpersons.
Yeah,
Thank you, Sneha ma'am.
Very, very important input from Dr. Jyoti. And if you remember, I had also, talked about this in my talk and after the discussion, that whether she is married or unmarried, if once you know that she is less than 18, you have to inform to police, let them do their job and you do your job. Your job is only to protect yourself. That is very, very important. So that's a very important, valid point, I would say. Thank you, Dr. Jyoti.
Thank you.
Okay,
Thank
bye-bye.
you.
Thank you, everybody.
Thank you and congratulations,
Bye.
Madan. Very
Yes.
nice CME. Congratulations, Minal. Both of you did a great job. Thank you.
Thank
and
you so much.
Thank you for
Congratulations.
involving
Thank
me
you.
also.
Thank you, everyone. Thank you.
Hearty congratulations, everybody. Thank you so much for joining our
Thank you, Sneha ma'am.
program. Yes. Thank you so much. Bye-bye.
Best
All the
wishes.
best, everyone.
Best
All the
wishes
best,
for you,
Neha, ma'am.
Supriya
Thank
ma'am,
you, Madan.
Mitra ma'am,
Thank you so much.
Thank
Sneha
you,
ma'am.
thank you,
Best
thank
wishes.
you. Thank you.
हमको जरा societies nominate कर दीजिएगा. Thank you so much.
All of you, please fill
Thank
the
you.
nominations. I have also, shared that file where you have to enter. So maybe the unopposed candidates information also we have provided with you so that you can fill, the one who is remaining. So I have made your job little easy. Please do nominate all of us. Thank you so much.
Thank you, ma'am. Thank you. Bye-bye.
Chalo, bye-bye. Good night.
Sneha ma'am, we will meet for IMA webinar.
Yes, immediately.
Immediately 9
yes.
o'clock. Yeah.
Chalo.
Thank you, ma'am. Thank you.
Bye.
Bye-bye.